All right. We are going to get started here in just a few minutes. So, hello, everybody. Thank you all so much for logging in. There's going to be a lot of people on. We know that there's going to be some patients. We know that there's going to be some docs. The first part of this video is we are going to it's about an hour-long webinar that myself, Dr. Evan Katz of Katz Chiropractic, Digital Motion X-ray, and something called Professionally Integrated.com, and Dr. John Schultz, MD, who is one of the owners of the CENTENO Schultz Clinic and REGENEXX. He's one of the only docs that does the PICL procedure. And what we did in this one webinar is we talk a little bit about the treatment that we do in our office called it's CBP, chiropractic biophysics, as well as some other treatments in digital motion X-ray to restore the curve. But we're highlighting a little bit in this one about what Dr. John Schultz does. And we talk about different types of treatments, why some treatments we think are better than others. And we do know that there's a lot of patients out there that get bounced around, get brushed to the side, and are having providers that don't really understand what's going on or don't want to put in the time to figure out what's going on to help. So we're here to hopefully bridge that gap, to let you know what is out there, that there's providers like myself and Dr. Schultz, and there's going to be other providers on here that are professionally integrated docs that you can contact me after. If you were not close to you and you need to follow up with someone out there, you can put your names up here, email, and we'll try to find you the appropriate provider. So let's go ahead and get this started. And then afterwards, we're going to have a live Q&A. We are going to try to answer as many questions as we can. If we do not answer your question, we're not ignoring you. We're just trying to follow as much as we can. We do have some questions that people emailed us, and we're going to try to do the best we can. We're going to try to give as much time to you as we can. So without further ado, let's get this started. And you could always ask questions. There's something here about chat. You could ask questions. And we're going to do our best to answer those. So we're here really for you. We just want to give information about a lot of the injuries that we see, a lot of injuries that can be treated, a lot of injuries that have particular treatment methods, and a lot of treatments that you may have questions about that from the medical side that Dr. Schultz does and why he does certain things, why he doesn't. So let's go ahead and get this started. And I'm so excited that you're all here. Professionally Integrated, thanks so much for joining for this really great webinar. I have here Dr. John Schultz, who is one of the founders of REGENEXX at the CENTENO Schultz Clinic. He's treated myself, my wife, many of our patients. He's just an amazing, smart provider. So I want to say thank you so much for taking the time to be here today.
Well, thank you, Evan. As you alluded to, we've had the opportunity of working personally and with some mutual patients, and it brings me great joy to be part of this community, because it's this community that really understands the issues of the spine, stability, and preventative care. So thank you very much. I feel like I'm part of the brethren. So because so many of the MDs and DOs simply don't get it, and your community embraces it fully. So thank you.
No, thanks for saying that. And a big part with Dr. Schultz here is many of us as chiropractors, we're going to see, and we're going to talk about this, instabilities, radiculopathies, degenerative changes, abnormal curves, upper cervical instability, joint or extremity issues. And I can say this, I've never lost a patient to someone at REGENEXX. We work together, right? And we want to learn, like the main thing is how do we get this person better, right? The main thing is what can we do together?
And that's the key, right? It's about the patient getting better.
So they obviously do things different than we do, but together they can work great. So we're going to go over a number of things. One, we're going to talk a little bit about how Dr. Schultz here can help your patients with telehealth and give advice on what they may be able to offer, and also why your treatment may be helping the patient and how you can work together. But we're going to start with just looking at things that many of us have questions with, right?
Sure.
So let's just start with cortisone injection or no?
Oh, yeah.
and why? And when would you use it? And when would you go from something else? So, can you just talk to us a little bit? You hear people saying, I'm getting an injection, right? And usually, I think not in your world, but in the world of getting injections, in the world of a lot of docs that I talk to, like, oh, I sent a patient for a facet injection,
Right.
or usually it's steroids.
It is.
It is.
It is.
So,
and it's high dose steroids.
okay.
So steroid is a very effective anti-inflammatory. That's the good news, and I think everyone knows about it. The bad news is it can hurt lots of structures. It can actually hurt the disc. That's why in many cases you're getting the injection. It can also hurt the facet joint, but equally important, it can compromise the very ligaments and tissue that's holding that joint together. So we see that as a very poor choice.
Okay.
So steroids are not good. It increases the risk of fracture, particularly in the elderly patient. So we do not have any high-dose steroids in our office.
So, do you use a low dose every once in a while?
We do use, just like just an example, milligrams, between 4 and 10 milligrams is what the traditional pain specialists will use.
Per injection?
Per injection.
Okay.
So it can be a particulate or a non-particulate steroid, and that's a separate issue, but if it's a non-particulate, that's a large dose. And what needs to be known is there are no randomized controlled studies. There's nothing that says you need Solumedrol at 8 milligrams. It's never been done. It's just being passed down from generation to generation. So
wow.
That's never been proven.
Wow.
Yeah, wow is right.
So there's no randomized control studies on steroids?
On high dose,
Really?
you know, like 4 milligrams versus 8 grams? No, not at all.
Oh.
So it's detrimental, and it can actually facilitate the degeneration and decline in some patients. So what's an alternative? If you had to have an alternative that wasn't a regenerative one, you would simply do a local anesthetic with a nanogram dose. So there's a milligram and a thousandth of a milligram, there's a microgram and a thousandth of that is a nanogram. And that's not commercially available. Oh. You can't go get in Boulder Community Hospital or anywhere else a nanogram dose. You have to go to a compound pharmacy.
Oh,
that's what you got to do, and that's what we do. We don't have any high-dose steroids, but the low nanogram dose can actually decrease the inflammation along a given nerve. For that patient that has that hot radic,
right.
Guess what? You can actually soothe both the annular tear, maybe the radicular pain, and get them to a point where we can refer them back to you, because I need you as much as you need me at times.
Right, sure.
I rely on your community at large. I don't have that skill set.
Right.
So I'm dependent on other providers to help the patient. So it's a win-win situation.
Absolutely.
So you put the fire out, and then you get them back into therapy.
Right, get them moving. So I know I jumped a little bit, but can you tell us a little bit about your background? Like I know. Yeah. Sure. I give a shout out to University of Utah.
Yeah, yo Utes.
Tell us a little bit just about where you went to school and.
So I'm an anesthesiologist. I'm double boarded both in anesthesia and pain. I went to the University of Utah, did anesthesia, and then I did 2 fellowships. I did the first fellowship in pediatric hearts. I know it's a little bit different than what I'm doing. I was at the University of Pennsylvania, CHOP, and then I did a stint in the Army, and then I came back and did a second fellowship at Bowman Gray, which is in North Carolina. Then I came here to do some post-grad work, and I found out, both Dr. Centeno and I worked together, that truthfully, high-dose steroids, ablative procedures, radiofrequency ablations, discograms where you inject the contrast into a patient, and yes, I've had 2 of them, and then the narcotics, it didn't work. Right. Those patients came back and back and back, so it really was a soul-searching period of our lives that we realized it was a very exciting and busy practice, but the patients weren't intrinsically getting better.
Right, and this was also during the time of like the opioid epidemic.
Absolutely.
Right, this was during that time
when the reps all promised you that there would be no addiction, right, and there'd be no dependence, and there's no way you could be addicted to those little lollipops or the transderm patches. Yeah,
Those are the teeth lollipops.
Yeah, we had grandmothers that were addicted to those. I mean, now you go to a rave party and they have these things in their mouth. Imagine a bunch of grandmothers that are sucking on narcotics.
Yeah.
It wasn't funny because you know what happened? Then their teeth were falling out. So then they came back with no teeth or dentures sucking their little fentanyl.
On fentanyl.
Yeah, on fentanyl.
I remember those.
Okay.
So, all right, so we did
now,
We
7:30.
did the low dose.
He wants to jump in. How, then I guess I
we try to
assume I
fix the
go
mechanical aspect. We try to minimize the amount of stress on the joints.
request
But then the
remote,
next
high
phase, a
video.
lot of times, will be prolotherapy.
How do I get my video?
So you may go with that depending on.
Oh, or is it
Yeah,
just
so
like every other one? I just click
There's
down
kind
here.
of an array of different treatment options, and what Dr. Katz is referring to is prolotherapy. So prolotherapy, in the easiest of terms, is a proliferative therapy. Most commonly employs high concentration sugar. What's the goal? The goal is to create inflammation. I know it's kind of counterintuitive, but as you all very well know, that inflammation is the first step in healing.
Right.
So for those patients with, let's say, a ligament injury in their knee, you know, the MCL, the ACL, maybe a tendon problem, they all are dependent upon non-steroidal anti-inflammatories, so they've arrested the healing cycle. So prolotherapy in its simplest form is to kind of kickstart a frozen or delayed healing cycle.
Right. Okay.
And it works in limited cases for stability.
Right. And what we're going to do here is we're going to go through what these procedures are, and then Dr. Schultz and I are going to talk about certain pathologies and how he treats them and what may be best. So I want to just get through, like, you know, what are some of these things. So then after that, a lot of times it becomes PRP.
PRP, so platelet-rich plasma. I think everyone's heard about it. I think the Kardashians kind of brought it to, with the face. Surprise, surprise. Yeah, it's called the vampire.
All right, there you go.
That's not something that we endorse or participate in.
It's called what? The vampire?
The vampire, yeah. They use PRP, and they basically
like as a filler?
No, is a way to stimulate new skin growth.
Oh.
Yeah, they put them 1,000 different needles. But anyhow, platelet PRP has now become a standard in many treatment options. It is now front and center for lateral epicondylitis. It's now replaced it in mainstream medicine. You can walk into a university and rather than get a steroid, which could compromise the tendon and the joint, you will most likely get PRP. What's the benefit of PRP? It is, in the simplest of terms, there are different growth factors in the platelet. The two most common are VEGF, which will increase the blood flow and decrease the inflammation. So it can accelerate or fast forward some of the healing. And we've seen it. Now, beware, what people are calling PRP is not always PRP. So what I'm saying to that is most clinics will have basically a daiquiri mixer, you know, a blender, and they'll put their test tube in and they'll spin it. And that's under the assumption that all PRP is the same and that all patients have the same pathology, which we know is wrong.
Right.
In our clinic, we have a very large laboratory, so we can customize the PRP concentration.
Okay.
That's key, because what a 60-year-old needs versus what a 20-year-old is different. And in a perfect world, you'd want to customize that therapy, right? Not everyone's the same. So PRP has to be customized for the best clinical results.
Right. Oh, that's interesting.
Yeah.
So there are people that have just little centrifuges.
Absolutely. I would say the majority of the places, most clinics just have a centrifuge and they spin it, and it's one size fits all.
Okay. And then from there we have stem cells, and there's the real stem cells.
Yes.
And the not real stem cells, like the amniotic.
Yeah, and we're going to stay on the highway, I think, tonight.
Yeah,
we're going to stay in the lanes.
With what you do. The stem cells you do.
So in terms of the stem cell, we utilize, the majority of our treatment options are with bone marrow stem cells. So what that looks like is if you put your hands on your waist bone where your belt rides, that's your iliac crest, and we go and extract that. Okay. So that's bone marrow. And I'll talk to you about that a little bit more. The other way is through fat, and we haven't been as successful with that because it's in a fabric like a fiberglass and it's adhered. It doesn't work as well.
You mean as
like a stroma?
Like treatment?
Yes, sometimes we will use fat as an adjunct, not as a primary source, but let's say someone has bilateral knees that they want treated. And oh, by the way, I didn't tell you this, that we actually count the number of stem cells that a patient has. Why is that important? Well, we all know that dose is critical, right? I mean, you wouldn't just go get an antibiotic and take a pill. You want to know what the dose is. And so too with regenerative medicine. You want to know how many cells you get. Most clinics won't or unable to do that. So if someone comes, and we published this paper about 3 years ago, you need to have 400 million total nucleated cells for one knee. And if they want two knees and they only have 600 million, they've come up short. So one of the ways to gap that deficiency is to use some fat. It's not as good as bone marrow, but it's an option.
It's an option. Oh, that makes sense.
And then the third option is where you take the bone marrow, you isolate the stem cells, and then you grow the actual number of cells to a higher number. So you multiply them.
Right.
And in doing so, you get much more RPMs and much more ability to heal multiple joints. That's the good news. The bad news is it's illegal. I know, it's illegal here in the United States. But the good news is we took our practice offshore, and we have a clinic in Grand Cayman where that's available, where we can culture expand. Its perfect application is where someone that has multiple joints that needs it, or maybe a patient that has an autoimmune or has a dependency on a medication that we know depresses stem cells. They can go there and kind of offset their medication limitations.
That makes sense. That makes a lot of sense. Okay, so let's talk, before we get into the spine, let's talk a little bit with some extremities. You did mention the lateral epicondylitis, and I will say I did tear mine, and I couldn't grab anything working on patients. And you do the PRP, and it worked. Like, I never had an issue again after it healed. Yeah. After the injections.
And it's so important. I'm thankful that it did heal. But
yeah, like
our evaluation of his elbow and everyone else's elbow isn't myopic. That's to say, we're just focused on the elbow, because we all know that it's all integrated. So what does it look like? Well, we had to ensure that it didn't have a rotator cuff. Had to ensure that he didn't have a radic coming off, or even a subclinical radic. So to that extent, we looked at the neck, we looked at the rotator cuff, we looked at the range of motion, and then we put a plan together. And so that's the other part of our practice, that it's more inclusive, it's comprehensive, because when you start looking at the functional unit in total, you get better results. With better results, you change lives.
Right, and that's the thing that we should all be doing, right? Look at the whole body, right? It's the whole body. It's not just the elbow, it's not just the neck, it's not just the shoulder, the feet, like put it all together. A foot can change how your SI joint functions, right? And vice versa. And you also do, with this, with the imaging, you also use your diagnostic ultrasound. So, you know, looking at it, we had a tear, and man, it helped.
So that's critical. I mean, I know you all had fun during birthday parties of put the tail on the donkey, right? You were all blindfolded.
Right.
And that was fun at birthday. You know, you get the cake and you have giggles. But that's not okay. That's not an okay standard for any injection in any person at any time.
Right. You
okay?
gotta see it.
You got to see it. And in 2022, that's what your patients, that's what you should expect. And if they can't do it, walk away. And just to let you know, there are some people that are kind of fudging it, and what they do is they have an x-ray machine in the room, but they never use contrast. Contrast is dye. They're saying they're using x-ray, but they're doing everything blind. And last time I checked, the cervical spine is not the place you want to do it.
I mean, I know I have patients that are like, oh, and I was like, did they use guidance? I'm like, no. And I'm like, so they didn't know where the needle was? Oh, he's pretty good at it. I'm like, no, he's not. Or no, she's not. Like, you're not, I don't know. Yeah, that's kind of absolutely incredible. So let's talk a little bit, you talked about the rotator cuff, but one thing is, can we just talk quickly about ACLs?
Sure.
Like, what do you do with torn ACLs? Because usually there's nothing to be done outside of surgery, and there has been, you have been doing that. I think you've even published papers on it.
We have 3 publications. One just came out, a third one.
So let's make sure, you know.
So the first question, and thank you for this opportunity. The first question is, and it's not typically reported in the MRI report, right? So what type of tear do you have? There are 3 different types of tears, right? So can I use this?
Yeah, please.
So if this was the ACL, you can have just a little tear like this. So just a small partial thickness tear. It goes a little bit across the affected ligament. Okay, and then you can have a more extensive one. It goes like this, but the fibers are still intact.
Right.
So that you can even go almost all the way across. And then the third type is a full thickness. And we can't do anything with a full thickness, but you'd be surprised how many MRI reports don't delineate the actual type. So for those patients with a partial, sorry about that, a partial thickness tear, or a minor tear, or a full thickness that's not retracted, sort of like a rubber band or something that we pulled apart, we've had very good success in mending that radiographically and physically. So we've had MRIs pre and post that have clearly documented that, utilizing bone marrow.
Okay.
It's an effective technique. And last time I checked, there's almost an epidemic of young women playing soccer getting ACL injuries.
Right.
So we've been very pleased that we've been able to afford many patients the opportunity of an option other than surgery. Because what are the risks of surgery? They make it too tight, then they get arthritis. They make it too loose, they're going to get a rupture again.
Right.
And by the way, the ACL has 2 bundles. When you get a graft replacement, you get 1 bundle.
Right, they don't do the 2.
They don't do the 2.
What's the turnaround time that you see when people have a torn ACL and then you do that procedure?
You know, if they're compliant with the physical therapy, usually at the 3 to 4 month mark, they are starting to re-engage the return to play.
Right.
So versus 9 months with surgical replacement.
Right. That's awesome. Okay, so let's talk a little bit with discs.
Discs.
All right, so let's talk whether it's, I don't know if it's different or how you treat them with cervical or lumbar, but let's talk about a disc herniation or extrusion, or is degenerative disc without forming a stenosis treated differently. So how do you treat a disc? Like, what do you do for that? I know what we do, we try to minimize compression, and discs, you know, for me, man, they're so frustrating because they can be so incredibly painful.
They can be.
Like when they're hitting the nerve root, like they are, most people can't.
Yep.
Oh yeah.
I've been on the living room floor.
Oh yeah, I've been there. So what do you do? What are your treatments? Like, how do you treat that? What's the mechanism of healing from the treatments that you give?
Yeah. So obviously it's going to vary from patient to patient, but what, unlike the traditional pain clinics that, quote, look for a pain generator, right? We're going to do a diagnostic into this joint, or we're going to do an epidural into this little low volume. We actually work off a model that they're all interactive. I mean, the facet joint is dependent upon the ligaments are dependent upon the facet joint, and the facet joint is dependent upon the disc. So it all works together. So we have a comprehensive functional spinal unit where we address, that's right, the ligaments. You've never heard of it, a ligament injected? Well, you can see it under x-ray, you can see it under ultrasound, and we're meticulous in making sure not only are the ligaments all injected, but the thoracolumbar fascia, which is a fascial layer that comes up in the lumbar spine that then bleeds into the supraspinous, which then bleeds into the interspinous, which then bleeds into the ligamentum flavum. So it's really, truthfully, all connected. So we're meticulous in that. We typically also inject around into the facet joint, and then not an interlaminar epidural. So may I use this?
Yeah, please.
So,
and are you doing this mainly with PRP? Or
yeah, so this is PRP.
It's PRP.
PRP
okay.
is the benchmark. So there are 2 types of epidurals, and for those that don't know, I'll just take a minute to tell you about it. So an interlaminar just means that. It means that we're going to touch off the lamina and put it right in the main canal. Well, last time I checked, fluid goes through the path of least resistance, not most resistance. So if you have a big disc, it's going to go everywhere but where you want it to go.
Right.
So an interlaminar epidural is a very effective epidural if you're in labor. But I don't have those patients anymore.
Right.
So I'm an anesthesiologist. I used to have that. So what we do is We inject transforaminally, so these are the exiting nerve roots. We actually go in to the foramen, posterior to the vertebral artery, and coat the nerve such that it goes up and around the affected disc. And we use contrast to confirm it, and a millimeter will make the absolute difference. And unless I get a perfect flow, I don't inject the PRP.
A millimeter of needle placement.
Yeah, you just turn the bevel up, turn the bevel down, because unlike many clinics, we're not a mill. We don't want to ever be a mill.
Right.
Because it's that each patient needs to get better, and we will spend whatever time it takes.
Right.
So our procedures are at least an hour, whereas in a pain clinic they may be 10 minutes, because it's a churn and burn.
Right, they're just pumping
bang,
it.
Bang, get out, get out, get out.
Get it numb, just put it around and hope that it gives some relief.
But you can't physically inject the facet joints, the epidural space, the ligaments, and the fascia in 10 minutes. Or 30 minutes.
There's no way.
There's no way.
No. Okay, and then the point when you do that, you're pumping the PRP in to
so to decrease the inflammation, so let's say it's a radic, we're going to decrease the inflammation along the DRG, along the nerve root, but equally important, if we can get into this interface around the disc, our intention is, and it's been borne out, that by increasing the blood flow, you can reduce the disc protrusion, and if there's an annular tear, hopefully promote healing so it's no longer leaking, causing this chemical radiculitis.
Right. And that's what Dr. Schultz is saying too, is the disc doesn't have a great blood supply, so it's that imbibition from end plate to end plate, and getting movement and getting mechanics, and that's how we try to work together, whether it's on my neck or someone else's neck, is trying to then get it moving and trying to take advantage of that inflammatory response to get it to heal. So yeah, it's fascinating.
And so our treatment isn't complete just by doing the injections. Then we need help from Evan and his colleagues to mobilize those joints, to maximize therapy, to get range of motion and strength. Because one treatment by itself, in isolation, isn't the best alternative.
Right. It gives the patient relief, but then you want to get them better long term. So now let's talk, one of the things that we see a lot of, and I know the doc's watching, and we're going to break this down from mid-cervical instability, because I know we're going to spend time on the other aspect. So mid-cervical instability, one thing I know that a lot of injectionists can't do, and I realized you guys did do it, is ALL tears, because you have to go anteriorly.
You do.
You do. And on most before meeting you, I've never heard of an injectionist doing that. So you have an X-ray, an extension, or a DMX where you see increased angulation. It's usually the ALL, right? So how can he get to that? So let's talk about the ALL first, and let's
have some fun.
Yeah, let's have some fun, because most injectionists will not go to the front. But again, the ALL is all right here.
It's easy. It's a low-hanging target. You just have to have some familiarity and confidence in your skill set. So just to kind of give you an idea, when we do a cervical epidural, I'm literally right here. So I'm already in the front of the spine. For those providers that have experience with stellate ganglion blocks, it's a block for PTSD and other sorts of people with high sympathetic tone. It's literally right at C6, so down here, we go right here. So we're very familiar with this. And the beauty of this is with an ultrasound, you can see what you want to avoid. You know, the carotid artery, the jugular vein, the nerve, so you can get right past it. You can contact bone, and then you switch over to X-ray. You put a little bit of contrast. You can see beautiful flow up and down, and then you take a lateral, and then you see this nice brush of thin coat that's going all the way up. It's remarkable.
That's awesome.
And it's life-changing.
Yeah, you get right on the ALL. So,
you got it right there. There's
stability. Yeah, and again, before we even get into it, Dr. Schultz and I were talking about how so many providers, I'm not going to say MDs or DCs or DOs, ignore or acknowledge instability, but don't acknowledge the treatment paths that should be taken, what we could do in our office. So you obviously see a lot of instabilities.
We see it all day long, and we see people just either ignoring it or insulting it with steroids.
Right, just making it worse.
The classic is a patient with Ehlers-Danlos syndrome, and guess what? They got steroids. Now, that's just a recipe for disaster. You might as well put gasoline on the fire. And that's usually what happens with these poor patients.
I know.
Then they're deemed, unmanageable or emotional, or
I know.
it's because you compromise the already compromised ligamental structure.
Well, it's because they're taking a patient and treating them like every patient, right? Whether you were hurt, or you have EDS or not. So now from the ALL, in the paper that we published in the DMX, one thing we found was that facet capsular instability is a big issue.
Huge.
In injured patients. So, we have videos on how we can affect this in our office. We're not going to get into that, where, we help patients with the mechanics, the curve, strengthening, but then when they need the injections, you're obviously not doing cortisone. So how are you just injecting those capsular ligaments? Are you getting into like the intertransversari as well on that side? What do you do with that?
When we put a needle into the facet joint with PRP, we also come out and engage that capsule. We can demonstrate it with contrast. So too with all the ligaments posteriorly, we can either do it with ultrasound or X-ray, including those ligaments that bleed into the myodural bridge, right?
Right.
The POM, which will probably be in a little bit later segment.
So one time we had a patient that was in a crash and we showed capsular instability. And I remember you did an image where when you put the dye in, it just explodes.
Yeah. It doesn't
stay in.
It doesn't stay in.
Right. It just travels out and goes everywhere.
Extravasates into the epidural space or outward.
Right.
Absolutely.
And that's something too, when you're seeing a patient, let's say in a crash, and you're getting the additional objective documentation, you do a DMX, they have facet capsular, symptomatology, sclerotogenous, and then you do an injection. You could also just show how that capsule is not holding that fluid in anymore, and that's a ruptured.
That's a ruptured capsule.
That's a ruptured capsule.
And we see a lot of those in the motor vehicle accidents.
Yeah, for sure. So now when you get to the posterior column, right, like the interspinous, the supraspinous, which I know you can get to pretty quickly.
Easy.
Can you get to the ligamentum flavum?
You can.
You can.
You
just through the back before, or through the
posterior
aspect.
So what's interesting is for anesthesiologists, there's a technique for the intralaminar epidural. It's called loss of resistance, and or you can do a hanging drop. So basically, you're driving a needle, and when you get a change in the resistance, you've popped through the ligamentum flavum. So you've already gone too far.
Right.
So in that breath, or in that same concept, what we do is we touch lamina and then engage the ligamentum flavum because we can feel the tactile difference. Then we do a ipsilateral contralateral flow and inject contrast, and it goes right up. It's beautiful.
That's awesome. And then you
do it bilaterally.
follow with the PRP.
We follow it with the PRP.
So does the ligamentum flavum keep some of those inflammatory chemicals away from the canal, or is it okay if some of that, like even when you do the epidural, you do the facet capsule, some of those inflammatory chemicals can get into the canal.
They can.
And
but we're not injecting any inflammatory. We're only going to be injecting only PRP. We're not going to be doing.
PRP can cause an inflammatory cycle.
It can, but it's got also very effective anti-inflammatory.
Right. Okay.
So the balance is it's going to be more anti-inflammatory. We'll put out the inflammatory agents in the ligamentum flavum and also around the canal.
So why? And I tell patients this because I've been there. Is sometimes there, look, the area is already damaged, right? And now you're going in and we're trying, same thing when we adjust patients, like I'm sore, like, yeah, we need to get blood in there. We need to break up the adhesions, and scar tissue is not good, but it's alive, and we need to break it up to get it to lay down in a better way, and that can be uncomfortable. But with the process sometimes where the patients are in discomfort, which ultimately can be very good, but how do we, or you explain that to the patient that we expect that to happen because it's a phase of healing, and then what can they do to minimize, because I've had some done where it was uncomfortable, and I've had some I'm like, oh, just my symptoms went away and I'm not even sore, and other patients too. So how do we educate these patients if let's say someone isn't here, the doc refers to you, they come in, they get their procedure, and they fly home, and then they're going to one of these docs watching like, man, I'm really sore after this. just give us a quick
couple things.
Yeah.
So number one, thank you, number one, for acknowledging this is an often unrecognized and very not discussed very much. So number one, all the PRP and all of our injections have some local anesthetic in it. Now, you probably don't know, but lidocaine in high doses actually impedes stem cells, as does the most common local anesthetic in the orthopedic community called bupivacaine.
Okay.
So it is never to be used with stem cells, but with the PRP we use a designer local anesthetic called ropivacaine. And so we're not cruel to the patient. There will be a component of some numbness. Okay, that's the first part. Number two, we're always very thorough to explain that more likely than not, you will have an escalation in your pain. And for those patients that have a disc protrusion or disc narrowing or some foraminal compromise, by putting in the PRP, you actually may exacerbate transiently the symptoms, but they're going to get better
Because it's
making it even tighter.
It's making it tighter, and it's bringing in
some blood flow.
And it's bringing it right, which is.
And then for the other part of the injections, the ligament injections, there's a great YouTube, which I know you're going to provide a link to.
Yep.
It just shows the 3 different phases of ligamental healing and the different times. And when the patients and the providers understand that it's a triphasic approach and it takes weeks for it to work, it's a better understanding. So the little bumps and speed bumps that they have and setbacks, it's okay. Because at the end of the day, they're going to get through it.
Right. I mean, that makes a lot of sense. So we went the facet route, and then, so now we're going to switch gears before we get into what you guys really invented and are the only ones that are planning to do. But I sent someone over, and in all the years that we've worked together, there's only been a few patients that have gotten this, and one, it really helped. And it's not like you do this, or at least for my patients, you may do it routinely, but hydrodissection, right? So let's talk hydrodissection. Like, this is something you offer too. And when do you offer that, and when is it something that, you know, we can say, hey, as we're adjusting you and working on you, here's an option, and can you just explain how that works and when you use that?
So hydrodissection is simply a ultrasound guided procedure wherein we visualize a given nerve, whether it be the median nerve or the ulnar nerve, and we, under ultrasound and needle, injecting PRP and local anesthetic, we dissect some of the scar tissue that's matting down that nerve. And so in doing so, it's a twofold process. We're mechanically taking the adhesions or scar tissue off of it. That's very common in like a carpal tunnel.
So as you're putting the needle in, you're putting pressure?
We're putting pressure. The needle is not doing the work.
Right.
What's doing the work is the column of fluid.
Right.
And you can actually see, we can just kind of just take layer by layer by layer. And then we're instilling PRP, which we know is rich in VGF, which increases blood flow. So now a nerve structure is not only having some of the compressive factors taken off it, but it also is being blessed, if you will, with some blood flow, which heretofore has never been done.
Right. So do you usually use that in peripheral nerves?
We do.
So
we can do a hydrodissection in the brachial plexus. That's pretty easy.
But not on a nerve root.
Well, the epidural will get the nerve root. I will pick up a C6 or a C5, and it'll go all the way up to the DRG. Then from the DRG, it will go through the foramen and across the pedicle and into the epidural space. So I usually get all of it.
Right, I understand that, but is that considered hydrodissection?
No, but it's the same.
Okay.
But and I'm not peeling it away, but I am coating it in a circumferential way.
But the peeling away, the hydrodissection, you
is
usually do
peripheral.
like
it's all peripheral.
Okay, that's what I was wondering.
Yeah.
Okay, yeah, that's so.
And it works. It works in a number of patients. It depends upon their pathology, their medicine, their chronicity, and how much compression they have.
Can you see the compression when you're
looking at ultrasound?
Absolutely. Yeah.
And that's the beauty of ultrasound. So symmetry, good, bad, or indifferent, it exists. So every time I have a compression on one arm, I go to the other to show them the comparison. Like, oh, you don't have any pain on this one? No, I don't. So we look at it. Look how big that guy is. Well, look how small this guy is. And then you measure it out.
Right, that's awesome, measurements. Okay, so now we're going to get into something.
Can we just talk about disc? One last question.
Yeah, please.
Okay, so
whatever you got.
So there's been some recent changes in kind of the regenerative world. Heretofore, everyone was very excited and utilized bone marrow concentrate in the disc. And that had good results. And then if you had the opportunity to go down and you have culture expanded, you even got better results. But the newest guy on the block, truthfully, is what's called leukocyte or WBC rich, white blood cell rich, super concentrated PRP. It has really rocked the world, and it doesn't require a bone marrow.
Okay.
It's easily injected. The patients don't flare, and the risk of an infection, i.e. a discitis, dramatically reduces because you've got the white blood cells, right?
Oh, okay. So how do you prepare that?
Well, same lab, because we have a custom lab. If we say we want a 25x leukocyte rich, that's what we get. You can't do that by a bedside daiquiri mixer. So we're able to do that, and we've been doing it both in the cervical and the thoracic and lumbar spine with good results.
Do you do a lot of thoracics?
Not a lot,
Yeah,
but thoracic discs are real.
Happen, right?
Yeah,
Right.
they're real.
Yeah,
I mean,
they're
they do
real.
get
Yeah,
injured, but just a home run.
So you literally are injecting the disc.
Yeah. So now the disc is as you know, is a very fragile, delicate structure, and I will do everything around the disc before I even consider going in, because it's a one-time deal.
Right.
And you can actually make damage by going through it.
Yeah, I mean, that's the hard. I mean, that's the one thing that's always been accepted is how do you make a disc degenerate issue, right? That's how they would do those studies on those goats or sheep was like, oh, let's cause degeneration on this, and they, you know, they kind of, and then just let it go for a couple of months, and they're like, oh, that's caused degeneration. I mean, it's different than a small needle and then trying to get blood in it, but yeah, I'm sure like the less you can pierce that annulus, the better.
It's a pristine.
Know? Even if the disc is already torn and there's tears in the annulus, there's already a tear in it.
You don't want to
but you don't want to do more, right? You don't want to do more.
It's sort of like a dural leak, right? How do you diagnose a dural leak? You do a CT myelogram by putting a hole in the dural.
Right. To see if there's a hole. Right. I'll never forget one time. I was at a lecture with Dr. Centeno, and he said, "Oh, a discogram." He's like, "That's when you put a hole in the disc to see if there's a hole in the disc." And I was like, "Yeah, I've used that. I've used that line." All right. So now let's get into. We talked about mid-cervical instability and lumbar. Now we're going to talk about, because this is something that we've been seeing, and when I say we, me, you, Centeno, we've had this DMX in our office for 19 years, and we've seen upper cervical instability since then, and nobody's listened. No one's listened right? Like we didn't know, and the $1 million questions, well, what do we do? Yeah. And I'll never forget when I was with Dr. Centeno. I remember Dr. Freeman was there, and we were talking about it, and I'll never forget, it was when Chris was like, I think we might be able to put a needle there. Yep. And we were like, okay. I mean, and then you guys got together, and but one thing I want to know is what bothers me more than anything when talking to chiropractors and people who quote unquote teach PI is they talk about instability. And instability, I'm only looking at flexion and extension. I'm not looking at the capsular ligaments, and not looking at mid-cervical. And the upper cervical spine doesn't have disc, doesn't stick within any OMSI. It's not even measured unless we're looking at the transverse, the ADI space. So you're missing so much when you're not doing, true stability, because you could have instability forward, you could have it from the side. Yep. So, and we've been trying to treat these. We've treated them conservatively here. But you have also developed a procedure where your clinic, and just the two of you in your clinic, right?
Mm-hmm. Correct.
So just Dr. Schultz and Dr. Centeno, I think you're the only ones in the world that are doing this procedure. You invented it. You put yourselves on the ledge that it's either going to work or it could end badly.
Yes.
Because whoever was like, let's try this, that was a huge risk, but that's how we continue to learn.
That's how the Wright brothers got airborne.
Or it's how we continue to push the envelope of healthcare to what do we do? Because what has been shown to help upper cervical instability, both on flexion, lateral, translation, looking at the accessory and alar ligaments, was fusion, right? And there's a time and a place. I'm not here to there's a time and a place for fusions. There's a time and a place for surgeries. But the outcomes that I've seen for 20 years in my practice, I haven't seen really like, wow, that really worked, right? And again, it's a hard area, no fault of the surgeon.
Yep.
You have an instability, they're going to try to stabilize it. And how do you stabilize it? So
You use with their tools, right?
Right.
That's the only tool they have in their box.
right, and they certainly weren't coming to chiropractors being like, oh, can you fix this? Even though there's good evidence that something we submitted for publication, hopefully we'll hear soon, of how we've been helping these patients for 20 years once we knew it. But you also have a procedure that you're the only ones doing this. So all of you, if you're doing DMXs and seeing upper cervical instability, a co-management and an option, right? I always give my patient options. I'm never gonna lose a patient to a surgeon or to him is, hey, here's what I have to offer. Here's some other things that are done. We can work on. I want that patient to choose, right? Give your patients options in conjunction with your care of what else is out there. They could do nothing.
Yeah.
That's their right. My body, I'm not
a
doing
viable
anything.
option.
I'm gonna live like this in a, at my house and do nothing. Totally, okay, but I wanna give you what the options are.
Right.
And I want to explain what the outcomes are if you choose to do nothing, this path, that path, right? That's what we should be doing. And again, on Professionally Integrated, all the research is there to show what these injuries mean, both in the short and long term, and what we could do to help. So now, with an option of your procedure, and I'm gonna let you,
Sure.
people call it PICL, right?
Yeah.
And
That's an acronym,
PICL?
right? Yeah.
But let's talk about what the P.I.C.L procedure is and how you came about doing it and how you got the confidence to say, let's do this. Because you had no one to teach.
Yeah, no,
you.
there was no. But before we get there, should we talk about symptoms to most of your colleagues?
Absolutely.
I think I have a lot of regrets and sorrow for these patients as a whole. So I think as a service to the community at large, let's kind of talk about what these patients are, because all too often they're shamed, right? A large number, they're females, and they get pushed to the side. They're psychiatric, quote psychiatric, perimenopausal, and they're discredited.
Or they were in a crash and now you're just trying to get money. Right?
So
like,
it's disgusting. So it's the nice thing is that an opportunity like this is to elevate this dialogue, so other people, maybe that light will go off. Maybe you'll be like, well, that doesn't quite fit in this box, but maybe there's something else. So what are some of the common symptoms that you see? I think it's just important that everyone should just have in the back of their mind, you know what? This could be an upper cervical injury. Right. So here we go.
So one of the things, and if you look at the sclerotogenous, if C0, C1 is here. So how many patients you see like, I have headaches here. Suboccipital spasms. We can sit here and be like, you have suboccipital spasms. That's the mild dural bridge. Is that from upper cervical instability? You don't know unless you rule it in or rule it out. We see dizziness.
Oh,
right?
yeah.
Especially tilting, like, oh, I'm on my phone, and they get dizzy, or their head is down, they get dizzy. Their head feels heavy, right? So you maybe see the Russ sign, or towards the end of the day, they're doing this.
Or how about, well, in the middle of the clinic, they've just kind of slowly descending. Now their head is against their wall.
And trying to hold it.
That's always a clue that their head is heavy.
And then, you'll see the nausea, even some vascular disturbances where they kind of can start to get blackouts. Yep. And then there's the other things that you may not attribute it to, like tachycardia.
The POTS syndrome, right? The
POTS syndrome, where they move. And
postural orthostatic tachycardia syndrome.
Tachycardia syndrome. Their pulse goes crazy. They just, if you weren't aware of it and you were a provider that wasn't paying attention to what all the research is showing, you would think this person's crazy. Right. Or they're making up these symptoms. But these are all very well documented symptoms that you have to, just like anything, whether it's mid-cervical instability, you have to put the pieces together. And those pieces are their history, maybe something.
The onset, right? What was the trauma?
What was the trauma? Maybe they have EDS.
Do they have an underlying, right?
Right. All these things. And then what do you find in your palpation? What do you find on imaging? What do you find on static x-ray, on DMX, on MRI? And then do those things correlate? So
absolutely. And the other thing that I would add is the brain fog, right?
And the brain fog.
Have you ever had just a bad hangover and the next day you can't ignite, you can't get a clear thought. Imagine that these people live forever like that.
Forever like that.
And then the tinnitus, right?
Yeah.
The ringing in the ears and the GI upset. So that's kind of the classic symptoms that we've been seeing, and they need to be, number one, honored. And for those providers out there, think, well, maybe it really is coming from the upper cervical spine, because the neurologist is clueless. The neurosurgeon is clueless.
Which is super weird, the neurologists are, because look at the neurology of the upper cervical spine.
I know,
and
but it's not in their base.
Instability, like it correlates so much that it's fascinating how it all makes sense.
If you've walked down this path. But if you never walk the path, you're like, and then how many people spend literally thousands of dollars going to the cardiologist?
Right.
They have echocardiograms, they have stress tests, and you know what? They're all normal.
They're all normal.
And then let's talk about some of the flaws that current technology. An MRI, more often than not, will be normal. One of the reasons it will be normal is it's a static test. The other problem is it only goes to C2. It doesn't even evaluate. So,
and even with that, not to cut you off, with the MRIs, we were talking before you came in, the one paper I was just doing that will be up soon is, if the ligament is overstretched, it's intact. So an MRI is like it's intact.
Right.
But if you move it, it's unstable. And what the one study that will be on the site shows is that a completely ruptured or an overstretched ligament completely, it does the same thing. It loses the integrity of the spine. So an unseparated ligament on MRI is the ligament's intact, but you don't know, right? So there's movement, which is why we want to palpate too. Sorry.
No. I mean, it's just so important. So to know that there's both dynamic and static tests.
Right.
And then there's now, in some communities, there's actually a dedicated cranial cervical junction MRI. But then you, of course, have to have the radiologist willing to go out on the line, because it's a thin structure.
Very thin.
So,
yeah.
Thank you, Dr. Rosa, out there
for
for leading the pack.
Yes.
We are grateful with Dr. Harshfield.
So talk to us when you both started this, when you started to do this, and talk to us about this procedure.
Yeah, so we, like previous patients that were having the high-dose steroids, the narcotics, and the destructive, they weren't getting any better. So too were a subset of our patients that either had connective tissue disorders, ligamental disorders, they weren't getting better. They have the MRI evidence of an ALR injury, but as you can see, our background is so this is anterior. We're very accustomed from working posteriorly, but you're going to transect someone if you're coming that way. So Dr. Centeno was responsible for this technique. There's a foramen, a hole through the 1-2 that allows us to actually contact and inject both the alar and the transverse ligament. So the alar connects the occipital condyle to the C2, and it comes up like an angel's wing. Whereas the transverse is basically a seatbelt. So it was that vision from Dr. Centeno, and a lot of very late nights and changing of scrubs after the procedure of can we really do this? Because recognize we're right adjacent to the cord.
The brainstem.
And the brainstem.
Yeah.
So this is a game changer. And after we've done about 1,000 now, we've developed better techniques and better approaches. And just as of yesterday, now we're the only place in the world that I know of that we have 2 C-arms. So rather than having to go AP lateral,
during the procedure?
During the procedure, we now have an AP that's fixed, and we have a lateral that's fixed. So
you can do one or the other, or you have them with both on?
We can have them with both on.
Okay, so let's say, I think you're simplifying it.
Yeah, I am.
Right? and what I mean by that is, going anterior is great, but how are you getting there? You're going through the mouth.
We're going through the back of the mouth.
So let's talk about the patient procedure. Obviously, the mouth is a dirty place.
Mouth is a dirty place.
But
every ENT it works in this space,
100%.
right? I mean, the tonsils and all the abscesses and all the uvuloplasty. So we have a strict sterile technique, obviously. We have an antibiotic regimen before. There's a mouth...
That the patient has to take, or a swab?
Both. So there's a swab, They gargle with an antibiotic mouthwash. They have IV antibiotic. And then the game changer is we patented an airway that allowed for the posterior pharynx to be visualized, but it also allowed for depression of the tongue. That enabled us to go next to that punching bag known as the uvula, because that's our point of entry. So we're able to visualize.
Right behind that.
Right adjacent to the side. So if I'm in, we're going right there.
Okay. So you do 2 injections.
One on the left and one on the right.
Through that foramen.
Now, that's part 1. So for the maiden flight, the patients that come there the first time, we restrict or limit rather our injection to going between the 1-2, and we inject the lower the lower alar.
Okay.
Why? Because we don't want to rob a given patient of their ability to heal. If you've ever done too much on someone, you know they curl up in the corner, and that can be for weeks or months at a time. So that's what we do in conjunction with the posterior 0-1, 1-2, 2-3, and all the ligaments. When they come back, and more often than not, they do need a second procedure, then we come above the atlas, we caress the dens, we get the apical ligament, then we get the superficial AAOM, we come back and get the tectoral membrane, and then we get the upper fibers of the alar. So it's a much more involved procedure the second go around.
So you're going back to that tectoral membrane,
yes,
which is the continuation of
the PLO.
Right. That it becomes the tectoral membrane like C2 up. Wow. Okay. So you usually are doing 2 of these per patient.
At least.
At least.
Yeah.
Right.
And I always tell everyone patient that they will require more than 1. And do we have failures? Absolutely. I mean, it's just going to happen.
Right, and you're dealing with, like, anytime that we, and I tell patients this too, when they're coming in, there's a spine problem. That area is already weaker, it's already hurting, it's a problem. We're doing everything we can to get it better. So not trying is the real failure, not trying to help these patients and educate them is the real failure. No one has 100% success rate with anything, right? So, wow, that's...
So let's talk about who's a candidate, right?
Yeah,
so you need to have the symptoms, right? And we would like, if possible, to have an onset, right? I mean, was it the rugby player in the United Kingdom? Was it the motor vehicle accident? It helps if there's a clear delineation of onset of symptoms. Right. So that helps.
Yep.
And then imaging, you have to have imaging to support this, because we're not going to do this procedure without support. And what that looks like is either a phenomenal quality DMX like you provide, a CCJ, MRI, or a rotatory CT.
Yep.
That's the bare minimum. There's no exceptions to that.
exceptions. Yeah.
And then they have to have failed conservative therapy. I mean, we're not going to just let someone walk in and say, well, will you put a needle in the back of my throat? Right. They have to have failed conservative therapy, including chiropractic adjustment, AO adjustment typically. Have they had no response from ligament injection, upper cervical facet injections? Because it's critical, and it's our responsibility to do the least invasive procedures that may actually help people so they don't have to have these more advanced procedures. So they have to have those to be a candidate.
And the thing too, for you docs out there, if you're seeing upper cervical instability and you're applying treatment either to upper neck, you're doing mid-cervical curve work like CBP, that's also been shown to be really effective. But you have to realize what's happening, because if you're adjusting the upper cervical spine or you're trying to stabilize the whole structure of the spine, how you do it will most likely change if you know that it's unstable. And that's the thing, like whether you go to an AO doc, a CBP doc, if they're not really evaluating it, it's going to change what we do and how we do it. And that's what we've been doing for 19 years with helping these patients, is realizing this person is outside that box. And how we do it is going to be a little bit different than how we treat someone that doesn't have upper cervical instability, or how we're going to address or adjust that region. So yeah, and they are, and you got to slow down. You're not, if you see 10 of these patients in 10 minutes, you're doing a huge disservice in my opinion. So you got to slow down and really understand what is actually happening here, where the instabilities are, what side it's on, if it's a transverse. So Have you seen better or similar results if they have instability, let's say transverse compared to lateral, or is it just kind of?
You know, we're trying to crunch those numbers, honestly.
Right.
We haven't seen it yet.
Yeah.
It's too early.
Yeah, some people are getting better, and yeah.
Most patients are getting better. I can tell you that.
For sure, yes.
Out of 1,000 patients, we've had probably less than 50 just no improvement whatsoever. And we were clear with them at the outset.
Right, as we all should be, like, hey, we're going to do our best. No guarantees.
There was no guarantees, and we're sorry, but I don't think there's additional treatment. So we're not going to treat it anymore.
And then at that point, if they're really bad and they failed everything, do you suggest the surgery? Or
I do. I think, you know, knowledge is power. Right. So going and seeing a surgeon doesn't necessitate you having surgery,
right,
but at least it gives you a different set of eyes.
Right.
And there's one, a particular one in Long Island that will actually do traction.
Right.
Traction. And for those patients that have a aha moment that have failed our treatment, maybe fusion really is their best option.
Right. Right.
It's not what everyone wants, but at the end of the day, we want good quality of life for ourselves, our families, and our patients.
Right. Absolutely. Okay, so now let's get in quickly here.
Telemed?
Are you doing telehealth?
Yeah. Okay. So if you don't have the opportunity to live in Denver, Boulder metropolitan area, you still have a resource.
Right.
And so what Dr. Katz is referring to is probably like most of the world, a part of our practice now is digital. And what that looks like is we have an education system center that will, if you have a referral, you can just email me. Dr. Katz will give you our contact information, and then I will send it to the education center, and they will work with your patient to get all the necessary information. And when all that's ready, we will jump on the phone, and if you want to join us, that'd be great. Some chiropractors have joined, and it's really been quite fun. During that 40 minutes, what we do is review the history, the onset, the treatment to date, what's it costing that patient. In other words, I mean, I saw 2 patients today that are basically bedbound. They're not getting out of bed at all. So what's it costing them? We look over imaging, and then we assign basically what type of patient are you. There's 3 categories of candidacies. There's good, fair, and poor. I type it all up. I tell them my professional opinion, and then if they want to proceed, we have someone that's willing to coordinate them coming out to Colorado. Oftentimes they don't have a digital motion x-ray or a good quality digital motion x-ray, so Dr. Katz has the opportunity of providing that to us in advance so the patient doesn't waste their time.
Right. And
when we come together as a family, oftentimes, they're there with their loved ones, we have it all right there, and then the decision's easy. They either want to proceed or not.
Right, and they can always come out if they're going to see Dr. Schultz, and if you don't have a DMX, we'd love to do their DMX. We're the author of the paper, so that holds some weight. We're going to make sure it's done correctly, and then we send it directly to you, and then Dr. Schultz will see the patient, and you manage care. And that's, and that's not just for upper cervical, right? That's no. If they have a crash and they have instabilities, and your treatment is helping, you can get Dr. Schultz to do telemed health to discuss what these injuries are, document it, get them the treatment they need here, and then if they do come out here with him, then send you back for the post treatment.
Yeah, absolutely, it's a critical part.
It's a critical part. So there is finding the resources of docs that are educated. I want these professional integrated docs to be, that we think the same, but we just have different tools to try and help the same pathologies that we're discussing, and that's what I think good healthcare is and what it should be. Give the patient options, realize that there's things out there that can help, and then give them good docs to work with to be part. Now you can be part of your team regardless of where you live. They can, you can have Dr. Schultz come on and facilitate and help with your patient as well, and substantiate care, and so on and so forth.
Yeah, I mean it can be a very dynamic process, and you as providers can learn what is now currently available. Maybe you don't know, truthfully, what are all the options? What are we doing?
Right.
And equally important, you need to know, just like in your community, that not all providers are the same.
Right.
There are, we do not do Botox on Tuesdays and fillers on Thursdays. This is all we do. But that, you'd be surprised. I mean, many
no
pain
way.
docs do something on a couple of days, and they may do some anesthesia in the OR. This is all we do, and that's all we've ever done for the last 15 years.
Right.
It's a full-time job. We are committed. We have a fellowship program, so we're always training someone. We always have 2 to 4 publications per year, so we're committed to pushing this rock uphill.
Yep.
To the benefit the community and the world at large.
Yeah. Well, I know it took a bunch of your time, and you
been a
already worked
pleasure.
all day. So thank you all for logging in. Again, if you're not a gold or premium member, I don't know what you're waiting for. We're going to get access for everyone for this, but make sure you have access to the site so you can get all this information. You can educate your patients, your community, improve your documentation, all that wonderful stuff, just to, like he said, to keep pushing this rock uphill, to keep validating what's going on with our patients, keep validating our care, and keep educating ourselves. So again, thank you so much for everything you've done. Thank you for helping me and my family when we've needed a little bit more, and so on. And you're our pleasure. And thank you, for our patients and everything else. So yeah.
So here's your chance. If you want to learn about the regenerative, this is your opportunity.
Yep.
Thank you.
And we're going to put all of his information here for you. And if anyone has questions, if you can't find his information, you have any glitch, obviously you can just email us at info@professionallyintegrated, and we'll get you all of his information and put you in touch for you and your patients. So thank you all for logging in, and I hope you enjoyed this. And thanks so much.
All right. Hello, everybody. So hopefully you found that to be very helpful and educational. We're waiting for Dr. Schultz to come on in. We will say this. We're really good with the spine and extremities and helping patients. Oh, look, but we're not the best at I'm glad that this worked out because I am not the tech guy. All right. Well, welcome, Dr. Schultz. Thank you so much for coming in for the live Q&A.
Well, Evan, I just want to thank you and all your listeners, but most importantly, I just want to applaud and give you a shout out for a tremendous webinar. Your team, the dedication that you put forth, and the prep was impeccable. I was listening to the whole thing, and I just can't help but smile and know you made a huge impact. So I'm honored, and thank you for this opportunity. And to all the listeners or providers, thank you for taking time away from your family, your parents, from things that you can do. So we're grateful.
Well, thank you. And I definitely have to thank you and Joey, who does my filming and editing, and Stacy. I call her the queen of my IT. So thanks. So let's get into some questions. I know there's a lot. We have some that were emailed, and we're going to kind of talk and discuss. And again, for everyone who's listening, this will be up for you to watch at any time. So one of the questions here is for you, Dr. Schultz. Will PRP help with pain and limited active range of motion from Hill-Sachs deformity and a rotator cuff tear?
Okay, so 2 different questions. Will PRP help with a rotator cuff tear? Like we talked about previously, there are different types of tears. For example, we can have a partial thickness tear, which involves just a portion, or it can be more extensive, or the tear can be like this. So it's important to read your MRI report and talk with your doctors about it, because the type of the rotator cuff will matter. If it's a full thickness where the 2 ends are separated, PRP is no longer an option. The only option is surgical repair, number 1. Number 2, we've had the honor and pleasure of treating many hundreds, if not thousands, of rotator cuff. And absolutely, if you have a rotator cuff, just getting past the shoulder level or internal rotation, you struggle. So PRP has been very effective. And actually, the research is clear. What has happened in the past is tears are there most likely as a result of a decrease in the number of stem cells in the tissue. So the tissue is kind of deficient. So if we can bolster that by putting exact concentrations of PRP into the tear, home run, pretty easy. Hill-Sachs is a different issue, and it would depend upon the severity and the patient's issues. So yes to PRP with rotator cuff. And for all the listeners out there, please look beyond the shoulder. look at the cervical spine, because Evan and I absolutely agree that the two are intimately connected. And if you only treat the rotator cuff, you're doing a disservice to you, your patient, and the community at large.
Yeah, and I think that's important too. With a lot of the patients we see, they're like, oh, it's my shoulder, and then the shoulder gets treated. And it's very similar to someone saying like, oh, my butt hurts, and you're for a true sciatica or radiculopathy from the spine.
Absolutely.
You know, that it is really true where we, you know, a lot of you patients that are on here, you know, if you have what seems to just be a shoulder problem and they're just treating where the pain is, and you haven't had your cervical spine evaluated, both a physical exam, an orthopedic exam, maybe some imaging to see what really correlates. So be careful with that. One question I had messaged to me now is, and I have my answer to this.
Okay.
But what is the healing time for the PICL procedure?
What's the healing type?
Yeah.
What's the healing period
time
or the injection of the alar and transverse ligament through the back of the mouth for those people that don't know that acronym?
Yes. And what can they want to know, what can they expect afterwards?
Sure. And, and I don't mean to be vague, but everyone respectfully starts at a different point pre-procedure, right? Where are we on the tarmac? Are we all the way back, or more functionally, are we severely compromised? Are we coming from a state of being bedridden for the last 6 months? Or are we pretty functional? So that has a large amount of to do with recovery. In general, many patients report what's called a honeymoon phase. And what that looks like is between 2 and 4 weeks, due to the inflammation and kind of the the inflammation phase created by the stem cells, patients actually get better. Right. They get clinical improvement in their neck and some of their neurologic. And then unfortunately, like all good things, it kind of goes down and people get depressed, and that's when we get the emails. So typically for the first 2 to 3 weeks, it can be a little uncomfortable, escalation in symptoms, followed by some honeymoon, followed by a decline. Typically at the 3-month mark is when we want to get some input in terms of their improvement.
Yeah. And what we've seen in our practice with treating these patients, managing them, and they get the PICL procedure, and then maybe they come back, is it's interesting where some like, oh, I feel tighter with not much pain. And then others were like, I had to cancel the first week of appointments because right. But we've seen, you know, good results with the treatment and co-management, but some just respond different for a couple of weeks. And have you seen any explanation as to why that is? Like men, women, or the amount of instability, or what?
I think there are many factors, as you just alluded to, Evan. And I think one of them is a term that's called central sensitization. So central sensitization is where everything is escalated. So I use the analogy that now a tattoo, in my estimation, would be painful, right? You know, there's a gun going in. But if you had a sunburn before that tattoo, that's central sensitization. It just puts you at a different level. So those patients that are exquisitely tender, that typically go off the charts before this procedure, are those more likely than not to have that severe pain.
And to bring that up too, I can, on this site, Professionally Integrated, we're talking about central sensitization for you patients that maybe are being treated for a facet injury or have a facet gap, let's say on a DMX. There's actually studies that actually show within 1 day after a painful facet injury, it actually changes the spinal cord, leading to central sensitization. So you know, patients that have upper cervical, maybe from a trauma, may also have facet or even irritation with a loss of curve that can hypersensitize. And that's again getting down to, you know, all these other factors that can occur.
But what I would suggest to everyone listening, it's been my experience, and I know it's also been yours, Evan, that upper cervical instability robs people of their life. It robs them of their joy with their partner, their family, their community. And yes, it may be painful. It may be a struggle for 1 to 2 months. I admit that. But in the long term, we've changed lives. And rather than having your community providers just providing treatment for the symptoms, once you identify the underlying problem and actually treat it by injecting the alar and transverse ligament, we've seen profound changes. So 2 months is not very much time if you can change someone's ability to enjoy life.
Right. And I'll take that a step further, you know, even with myself, like as a chronic low back pain sufferer with trauma, it's not just upper cervical instability that can affect your life. Like spine pain in general is. And I think that's the whole thing, is looking at, there's more than one bone in the body. There's more than just an epidural that can help. There's facets, there's ligaments. It's why you and I and the other docs that are on here, I see there's one doc on here in Utah, Dr. Patrick Collin, who has a DMX. He does great DMXs and treats these as well. Dr. Miles Fortner in Wyoming is on here. And, you know, we that's why we analyze these things. Like, right. We're not just saying you have a headache, right? You have neck pain. Is what is it coming from, so we can get appropriate treatment. So let's see, we'll take a couple other.
Can I just embellish one on that?
Please.
And that's why it's so important. Working with you has been life-changing, because you understand the language. You have even taught me the language. It's developing a network of providers that can acknowledge it, see it, and treat it, as opposed to just stopgap measures with routine adjustments and or medication. So it's a pleasure. And thank you for doing everything you do with your website and bringing this severe problem to awareness. We're grateful.
Well, that's super nice, and back at you. And I think that's the whole point, especially with the docs that are on here and any patients that are listening. We're not Mills, right? We're not going to, you know, see 100 people a day. We're going to try to really examine and figure out what's happening. So someone's asking, what is the CBP approach to cervical instability? And that's for me. So we actually, what's fascinating is when you look at instability, I always go back to the definition of structure is any assemblage of material that's designed to sustain a load. So when you change the load, it can no longer, or when you change the structure, it can no longer sustain load. And in fact, that is instability. And White and Punjabi in their book, Clinical Biomechanics, that a loss of the cervical curve is a sign of occult instability, right? Looking at it, we do improve the cervical curve, because a loss of curve is abnormal load that's loading the discs and the facets and other things. That's instability. Now, when we talk about segmental instability or upper cervical instability, there's a lot to that one, because, you know, in CBP, we can pull a lot here and extend the head, but in a lot of upper cervical patients, especially if it's that apical or alar, from the side, we don't want the skull to extend. So we're trying to change the traction and how we do it, and slowly move into it. We also, we also published a paper, me and there's another great doc in Dr. Curtis Fedorchuk and Dr. Douglas Lightstone, where we published a paper in Journal of Musculoskeletal where we actually fixed spondies. And we published this where we took multiple patients, and what we did is we looked at instability and abnormal curves. This is before and after, and we even improved the cervical canal. So we show that we can do this in our office, and we got this. This is the first paper, I believe, non-surgical or especially chiropractic, that can fix spondies and improve the canal. So that's what we do, and that's what we've been shown to do, is by fixing the curve and looking at the instabilities. And a lot of instabilities, what you'll see, what Dr. Schultz talked about before, a lot of it is on extension, the ALL, right? So it will posterior translate. So we have no problem with getting you in a curve, but then pulling it forward so it can't posterior translate, and then try to stabilize it with, you know, home traction, the adjustments that we do. And then sometimes, you know, we'll co-manage a lot with Schultz to do some of the PRP and other aspects in that region. So that's what we've done there. So
that was a great picture, by the way. I bet most surgeons can't even get it to that degree, because you always see some sort of slippage above and below the fusion site. So,
well, what's interesting is we've done papers on that. We've talked to surgeons like, can't do that, and then we're like, we showed them like examples, and then we got me in another clinic. We were like, well, let's just do multiple clinics to show that based on what we're doing, we can do this. And again, not everyone, but we see it more likely than not. So let's see, there's someone I just want to read here. Saying a lot of his patients have been doing great with your procedure and stabilizing with CBP. And they sent you some patients and they've done amazing with your stem cell that they notice in doing well. And only with that treatment, with good CBP care, with Schultz doing the P.I.C.L, only about 1% to 2% are ending up needing surgery. And this is something I think we should all get together and write up with these patients, that the patients that are on here asking these questions, how can we do this and how can we, improve them? So one is asking, have you seen cases with C0, C1 congenital fusion, but with C1, C2 instability? And can you do stem cells an option with that region because it is fused above congenitally?
So the question is have we seen 0-1 fusions or 1-2 fusions with adjacent segment?
C0, C1 congenital fusion, and then so C0, C1, and then C1, C2 instability.
Yes, of course, we've seen that.
Yeah, and then
we've seen it. It's not as common as cranial cervical instability, but some people, for multitude of reasons, have had fusions, or it's a congenital fusion, and we get basically, as you mentioned, a disproportionate load on that adjacent segment. And we have treated it successfully. You have to treat the joint, the capsule, and the ligaments and their curve, thanks to you.
So now here's another question here. Talking about EDS patients, right? And, we see patients, someone here is asking Dr. Patrick Collin in Utah is on here, who sees these patients in Utah as well. And they usually can respond well, but they're a lot harder. And another question we have here written in with patients with EDS, when you're doing PRP and stem cell, and they already have a connective tissue genetic disorder, what type of outcomes can you expect with your PRP or stem cell into the ligaments that are already genetically unstable?
Sure, great question. And my heart goes out to all those individuals that have hypermobility and or EDS and that have had traumatic injuries. I acknowledge that life is a challenge for you all, and it's unbelievable the stamina and perseverance that you all have as a community. That being said, there, as Dr. Katz mentioned, there's a genetic problem with the ligaments such that they are loose at birth. Their response to PRP and or stem cell depends upon how severe the EDS is, how severe the trauma is. If you had a person with EDS and their twin without EDS, I would say in general, the patient without EDS is going to do better. But I can't really quantify they're 30% more prone to failure, or they need more treatment. It depends upon the severity of the EDS. But we've had such significant home runs in patients. I just give you an anecdotal who will remain nameless. This young girl was so compromised with EDS that she dislocated her hips and her ankles just walking to school, which rendered her into a wheelchair. You can imagine going to 5th or 6th grade in a wheelchair. So she's had several PRP injections into the entire structures, the hips, the knees, ankles, and she's back in school, not in a wheelchair.
Yeah, I think I know who that is.
Yeah, you do.
No. So I think it's fantastic. So we answered a bunch of questions. I know some people have texted and emailed. We're not going to stay on all night, so we'll leave this open. If anyone has any other questions, type it now or email us later, and we'll try to get back to you. And then from there, we'll start wrapping this up, because I know this has been long, and I'm sure people don't want to sit here for an hour and a half, 2 hours on a Tuesday night, but we do hope this was informative. And really the goal of this for the patients that are on here is there's a lot of providers, Dr. Schultz, myself, that are here to help you, right? We're here to give you the time that we believe you deserve and do anything we can to try and help. We're not, we're going to do everything we can. So we hope that you can feel comfortable with reaching out to us, making an appointment. And if we can't help you, like you can't come to us, we're going to try to find people near you. Like I know a lot of great chiropractors in a lot of regions that are associated with me, with CBP, with professionally integrated, and other chiropractors that are really knowledgeable in this. But again, it's like a subcategory of care, right? Like some chiropractors are really great with babies. I'm not one of them. I have expertise. It's not. This is an area of expertise that I and others have decided to focus on and dedicate our lives to. So let us try to help you. Sorry, someone is asking here, what is EDS? So sorry, EDS is Ehlers-Danlos syndrome. And it is a connective tissue disorder that can lead to a lot of hypermobility, meaning too much movement of the joints. And unfortunately, it affects the connective tissue, and that some of the connective tissue can also be vascular and organs. And there are some genetic tests, but really the way that you can identify it is something called like the Beighton score, where how flexible are you? Like, you know, can you bend this back? Can you easily touch the floor? Can you dislocate? And when we've seen patients, I have a video of a girl who can literally bend every, like it, I can't watch it, but it's called, so EDS is Ehlers-Danlos syndrome.
And there are different categories, right? And there's different severities, like everything else. So
yeah, so that's what it is. And it is fascinating that a lot of people do have it. And have been seen by so many providers.
Exactly. I was just going to touch on that.
You come in and you're like, so have you ever been talked about EDS? Like, no. And I've seen, and you're like, wow, within the first 5 minutes, a lot of times you could just, but anyway, so.
And does it show up on MRI?
No, right.
No.
Up on MRI.
So you'll get talked down to and said, well, your MRI is normal. It must be in your head. It must be hormonal or something. Many patients with EDS or hypermobility, regrettably, are dismissed.
Right. And remember this too, for the patients that are out there, there's a lot of evidence that MRI picks up a lot of things, but it misses a lot of things. And also a non-weight bearing MRI may miss a weight bearing MRI. Most of the patients we see hurt more and have more symptoms of movement. And there's a lot of evidence as to, you know, I wouldn't just do a static exam on you. I want to move you. I want to see what you look like and you're least comfortable. And that's the biggest negative we found in the DMX, if you call it negative, is it can flare you up because we need you to move to see what's happening when there's a problem. So is there a contraindication for chiropractic adjustment in EDS? This is a question we're getting. So there's a contraindication for every patient. It's about how that person with EDS is being adjusted and understanding where those instabilities are. So we've had great success with a lot of EDS patients, but we treat them differently. We give them, you know, we start them. It's interesting. We start them a little slower, but what's fascinating with EDS patients is they can take traction like nobody's business, and they love it. But they can do it for, you know, so yes, we do it differently. We analyze it, and a chiropractor, you know, if you have EDS and you're in their office and you're in an office where you're seeing everyone be adjusted and you're being adjusted the exact same way, you may want to start to ask a few more questions, because everyone should be treated a little bit different. But EDS can be a little harder to manage and should be looked at a little bit differently.
Absolutely.
So we'll open it for just like another 30 seconds to see if anyone has any questions. And again, the video will be up. Dr. Schultz's contact info is on there. My contact info is on there. We'll put this up on mine. Please feel free to watch it at any time. Reach out with any questions. And for the docs that are on here, super appreciate you getting on with Professionally Integrated. And again, if you have any questions, you're having a hard time getting in touch with Schultz, you can't find his info, contact us through Professionally Integrated and we'll email each other to, and the same is true when we see patients that are looking for a chiropractor in another state. We're going to look at our, you know, professionally integrated docs, the CBP docs that are associated with it, to try to find you first so that you have the information to get to them and this open line of communication. So yeah, that's all I have from me. Dr. Schultz, super appreciate all the work that you've done. You make me a better provider, and I appreciate co-managing patients. And I'm really lucky because I'm here in Colorado, not too far from you, which is great for me. So thanks for your time.
Thank you, Evan. And to all the providers that are listening, I hope you found this informative. I know we're taking time away from your family. I just want to tell you how you can have a patient evaluated without actually coming to Colorado. I conduct telemedicine evaluations after we compile their information, any imaging. It's about a 40-minute intake. And after that, I will give them a summary. And if you want to be on the line, that's great. Outlining their candidacy and what the next treatment is. On a side note, if any of the providers here have any questions, Dr. Katz will provide my email. Please feel free, because if we work together, we can change the community. If we can change the community, we can make a fundamental change in the health at large. And that's why I get up, and I know that's why Dr. Katz gets up every morning, to make a difference so that patients don't get dismissed as hormonal, crazy, or depressed, which is an all too common response for this subset of patients.
Or not just getting pumped with cortisone.
Or
and there's a time and a place, you know, when you're in bad pain, but let's figure out why you're in pain and get the appropriate treatment to fix it and not just cover it up. Yeah. So thank you all so much. And we'll talk really soon. Thank you.
Thank you.
Thanks.